All right, everybody. Thank you for coming to view our sports economics webinar series. This is the last one of this academic year, and we're really, really excited to have two experienced speakers on our panel. We're going to be talking about direct primary care, direct sports medicine care, kind of this direct specialty care model, and how they got started, how they're doing now, and then whether or not they have any tips or advice for everybody. So what I'm going to do is, let me go to my PowerPoint here, see if I can. Okay. So just a couple of reminders for those of you joining us, please mute your microphones and turn off your video. We want to maximize the bandwidth for our speakers as well. Please type your questions in the chat. And so if you have questions, the panelists are happy to answer them. And what I'll do is I will go one by one down the list and ask them those questions as well. Just a quick reminder, our next sports economics webinar series is going to be sports medicine practice in the Federal Qualified Health Center setting, so the underserved setting. It's going to be given by Dr. Julian Perez, and it's going to be the 28th of August at 8:30 p.m. Eastern Standard Time. So check that out, please. All right, so let me get over here. So I'm really excited to introduce our two speakers today. And our first speaker is on the panel is Dr. Daniel Clearfield. So he is the founder and medical director of Motion is Medicine, Sports Medicine in North Richland Hills, Texas. His practice focuses on osteopathic sports medicine, regenerative orthopedic medicine, non-operative orthopedics, osteopathic manipulative medicine, and concussion management. His innovative out-of-network practice has also led Dr. Clearfield to start a consulting services called Physicians Unchained, where he teaches other physicians to break the shackles of the broken healthcare system and to learn to start their own cash-based medical practice. Dr. Clearfield is a nationally and internationally recognized speaker in the field of sports medicine, regenerative medicine, and concussion management. He covers numerous area high schools and area sports, and he is an official team physician for the XFL's San Antonio Brahmas, USA Wrestling, USA Judo, and the USA Olympic and Paralympic Committee. He has covered sporting events all over the world, most recently serving as the USA Wrestling team physician at the World Rankings Tournament in Tunisia, Africa. So welcome, Dr. Clearfield.
Thanks.
Yeah, our next panelist is going to be Dr. Mary Tierney. And so Dr. Tierney is the founder and medical director of Walnut Grove Family Medicine and Wellness in Lancaster, Pennsylvania. She completed her family medicine residency through Penn State Hershey Medical Center and her sports medicine fellowship through Fairfax Family Practice and the National Capital Sports Medicine Consortium. Her practice is a direct primary care and direct specialty care clinic offering family medicine, sports medicine, and acupuncture. Her DPC practice offers full family medicine care, ultrasound-guided injections, concussion management, acupuncture, dry needling, regenerative medicine, and individually designed rehab programs. She has presented research both nationally and internationally, including at the International Olympic Committee. Currently, Dr. Tierney serves on the International Interorganizational Committee with AMSSM and serves as a team physician for the LPGA. She has a passion for reducing the disparities in the healthcare system and improving the quality of care through the DPC model. While she's not working, she enjoys serving her community through nonprofit committee boards, traveling, and spending time with her husband and two sons. So welcome, Dr. Tierney.
Thank you.
All right, so I am going to stop sharing now. And we have a lot of members here. So what we'll do is let me open up the chat as well. So if the audience has any questions, burning questions for our panel, please ask them in the chat. But while the audience is kind of churning out questions and thinking about questions that they might want to know, I am going to start with some questions for our panelists. So the first question that we're going to start with, and I will direct this to Dr. Clearfield first. What made you decide to go into direct primary care, direct sports medicine care, direct specialty care?
Sure. And just some quick background. So I started my career straight out of fellowship in academia. And so I taught over at the medical school over in Fort Worth for 6 years. I was a fellowship director. I started a sports medicine fellowship over there. Was pretty happy for a little bit, but then just the direction of the university started going in a little bit of a different way. And I ended up leaving and going into a private practice where I was doing the sports medicine there, but there were some promises made to me that never really came to fruition. And so I kind of worked in that primary care model. I worked as a specialist. I worked in an orthopedic model when I was in academics as part of the ortho department. And so where I kind of decided that I needed to do something different was, first of all, I started sensing burnout. I could see it kind of coming. I was really getting tired of, I'd really like to be able to do this for my patient, but because insurance isn't going to reimburse this, or because it's going to be such a pain to be able to do this, we can't do this now, or we have to jump through these hoops. And wouldn't it just be great just to be able to say, hey, this is what I think is best for you, and I'm your physician. Maybe you and me, the patient, should be able to make this decision without insurance, hospital, anybody else making those decisions for us. And so that's where I started saying, how can I do this? How can I exit this model? Because I feel like insurance keeps dangling something in front of us saying it's going to get better. It's going to get better. And we just try to put our heads down and we try to say, if I keep barreling forward, if I just put up with it a little bit longer, it's going to get better. And you know what? I don't see that happening. And I still don't see that happening. And following on our national listserv that we have, I just see people complaining about these issues a lot. And so it's made, so kind of fast forwarding to, do I regret this? Absolutely not, because it's such a better patient experience. And so that's what kind of led me down this path. I said, I wanted to make sure I had autonomy on how I can treat my patients. And I wanted to make sure I had autonomy on how I could be around my family. I wanted to have better control. So I said, I want to have my own practice so I have control over things. And then I wanted to be able to have control over how I treat my patients. And so that's what led me down this path.
Thank you. Dr. Tierney, same question.
For me, so I heard about direct primary care back as a resident, probably around 2013 or so is when we were getting lectures on it. And at that time, I was so focused on other like goals and objectives that I wanted to do. But it was months after I returned from my second maternity leave, it was the height of COVID, 2021, seeing about 30 patients a day, trying to balance good patient care, but also be able to provide care in such short intervals of time for much more challenging patients. And then my husband works nights and long hours in a very busy career himself. So trying to break away from the chaos, like Dr. Clearfield said, was really hard, trying to find that balance. And I also just did not see the tide turning. I kept seeing it getting worse and harder and more difficult. I was in family medicine and primary care sports medicine clinics separate. So I was 50% in each. And so, you hear this, just maybe back down some of your time. How could I back down more than 50% from two areas of medicine that I just loved? I really felt like I was going to get shortchanged, and I just was not okay with that. The second piece was, as Dr. Clearfield mentioned, when you're seeing that many patients, it's really hard to provide the care. And as primary care sports medicine docs, we have such a skill set that I think it's so important to be able to have the time with our patients to offer those treatments. And when you don't have the time or insurance is not on your side, how are you going to be able to deliver that type of care? As I realized that I wouldn't find the balance without breaking out of that mold, I started to investigate direct primary care. And when I started to realize how much financial waste is in our healthcare system, solely driven by corporate healthcare and insurance-based billing. And so I'd have diabetics or anybody that I would say, I need you to get this care. But then they would come back at me and say that they couldn't afford it. And when I started to understand the financial side of it, how do you treat patients who can't follow your directions solely because you're breaking them financially? So a big piece for me was it started to turn into a philosophical issue of driving me down this model, because I certainly couldn't go back. once I started to realize if you don't treat them from a financial side, how do you treat them from a whole care health side? So for me, it really became, I couldn't really turn back once I started to see that there was just a better model personally, professionally, but also for patients. And that's really where, I started to realize I see the tide turning towards cash-based systems, and I want to be part of the solution to our healthcare system rather than continue down this road where I see it only getting worse for the next generation. So that was really what pushed me into direct primary care.
Yeah, thank you for those responses. I think you guys touched on a little bit too of, kind of the effects of burnout and physician burnout, whether it's in a system, whether it is, the practice, or a combination of both. I think that's really important. That's something that AMSSM recently has kind of gone into as well. But I want to kind of touch base on that just a little bit more. In terms of burnout, there's a lot of different systems out there or healthcare organizations and employers who are trying to combat burnout. Do you think that it's actually a genuine effort on their end, or they're just kind of checking a box to combat burnout? Or is it, yeah, no, it's a problem with the system. You just have to exit in order to actually achieve, let's say, the so-called nirvana of direct primary care?
I think that's a really good question. And I often will look at a situation in a positive light, that I think people approach something with good intention, but whether or not it can actually change, I think, is a separate problem. I think people actually want to make a change, and they are a lot more tuned to the signs and symptoms, and hopefully more people, especially in the administrative level, will respect when, physicians need that break and that change, but whether or not they can actually provide it to the level that the physicians need. A lot of us in direct primary care and are in communities where we, have open discussion on social media groups, and it can take a different interval of time for each physician as to when they can recover from some of that, workflow trauma, if you will, to charting dozens and dozens of patients at the end of the day, when you're also trying to be present for your family. And that's just a piece that I don't think you can change in the current model or system that you have. I believe in the philosophy that you can't change a system with the same problem, with the same type of philosophy that started it. And I don't think you can change that without taking insurance and other payers out of that variable. That's just me.
Clearfield, anything?
Yeah, I was going to say that I think it depends. I really do think it depends. I think some people are out there and they're in a system that is extremely supportive of the physician. And if you're in that situation, then awesome, great. And I hope it stays that way. But sometimes things change. One of my mentors was with a ortho group for couple dozen, I think 15, 20 years. And things were going well. And he did a lot of osteopathic manipulative treatment. He did regenerative medicine. He was doing all these great things that was helping the patients. And then this new leadership came in and they said, hey, you're not sending enough of these cases to ortho. You're not sending enough to surgery. And we want you to be essentially we just want you to kind of funnel things over to surgery. We don't want you to actually get people better. They didn't care about outcomes. They cared about surgery and so that's where maybe you're in a system that's great for you and hopefully it stays that way. But sometimes things can change and it can unpredictably change. I was very happy at the medical school for 4.5 of the 6 years I was there, but then it started to shift. They started going away from an academic focused model into more of a business model, and it was a terribly run business. And so I was like, this isn't sustainable for me to be here. And so I needed to kind of leave. And then when I was in the primary care kind of setting, I was like, I felt like I hit my ceiling after about a year there. And I was there just under 3 years. And I said, I need to find something else. And I needed to kind of get off the Titanic. But I didn't want to be in the band playing as the ship went down. And so I, made sure I kind of got out of there before. And sure enough, like, you know, like right after I left the medical school, about 6 months later, the entire practice group kind of went under, and most people shifted over to the hospital system. After I left my primary care position, we saw that place kind of fall apart, and it's an unrecognizable clinic now. And so I'm glad that I have that control over my clinic now. But kind of going back to what you were saying, Eliot, is, you know, like, are there supportive systems? I think one of the best things is if it's still a physician-led system, I think there's more hope, because there's true empathy about what we've been through, what we're going through, who we are, our identity, everything like that. And I think there's more executives that have gone through their, you know, their specialty kind of training, and they've been real. Part of it is, how do you wrangle in these physicians and keep them dangling there, and make sure that you make them reliant, dependent on you. Make sure that you pay them a lot at the beginning so that they have all these big expenditures, so that they feel that they can't leave. They have these non-competes, so they feel like they're stuck here. I feel like that system really tries to harness that and make you feel like I have no other place to go, and trap you. And that's where a lot of people, I definitely hear the word trapped with a lot of people that I do like consultations with, and just talking with friends and colleagues. They just feel very trapped in the system that they're in. And, you know, so sometimes I feel like this model is part of the savior of medicine in a big scope kind of thing, just because a lot of us, you know, we get into medicine hopefully for altruistic, you know, kind of tendencies. We want to help people, and that altruism gets exploited by people that see dollar signs. And so I'm trying to remove myself from these things and take away all these extra kind of things where those people are affecting me, and just saying, hey, it's about me, it's about my patients, it's about me, it's about my family.
Yeah, wonderful. No, I completely agree. I think, you know, you guys hit on a lot of important points where, you know, leadership matters, but leadership can change. And I think, you know, that trap system is partly the reason that we decided to start these webinar series, is that, we certainly don't want everybody to feel trapped or saying, hey, I don't have any resources to educate myself or to support, myself, or find resources that I can kind of dig myself out of this. So thank you for that. So I do want to get to some audience questions. And so the first question, I'm going to modify just a little tiny bit as well. But the first question is direct care a supplement to your insurance-based practice, or are you solely direct care? I am going to add, do you think it's possible to have a direct care supplement on top of your insurance-based practice, or is it more beneficial to only have one versus the other? So Dr. Clearfield, I'd like to start with you.
Sure. So when I started this, I just dropped all insurances. So I've been at it for just over 5 years now, and I just dropped all insurances, Medicare, everything. I definitely know that there's some clinics that have a hybrid kind of model. And in speaking, especially being at conferences and speaking with somebody where they have a little bit of insurance they take here, and then they do a little bit, and they do cash, and maybe it's 50-50 or 60-40. Most of them find that they are trying to find a way to let go of the insurance. And I find when you have the insurance, it just becomes that much more difficult to find that way to, how do I transition away from this? And it's really, so it's almost easier just to kind of completely rip the Band-Aid off clean and start completely free of it, where you don't have to worry about that. Now, at the same time, sometimes insurance can serve as that kind of means of patient recruitment, getting people in your door that wouldn't otherwise kind of come in. But with insurance also, if you want to get any kind of reimbursement, then you have to carry more overhead to be able to support that. When I started this, it was me. My wife was working as a teacher, but she was my office manager, kind of helping on the business end of things. And after a few months, I hired an MA. And, it's like right now I have a bare bones staff. It's still me. It's my wife. I have an MA, and we have an intern that is pre-med that's kind of working for us right now too. And then I take medical students also. So, I mean, I can keep a very bare bones staff. I don't have to worry about this collection staff. I don't have to worry about all these other kind of things with insurance. I don't have to worry about insurance fraud. And the one thing I tell my patients is I'm outside of the insurance system, but I still have like my hand, I'm not putting my hand in it, but I'm a hand's reach within it. So I say to my patients, most of my patients that come to see me do have insurance. And I say, you can use your insurance. I'm just not using your insurance. And I was actually there, my residency was very good about teaching me about coding and billing, to the point that I was actually giving like, state and national lectures on proper billing and coding. I got audited several times and would never have an issue with my billing. So it wasn't a problem with my billing and coding. I think a lot of places, the system wants to gaslight the physicians into thinking that we're doing something wrong, and that's why we're not getting paid appropriately. And I was doing everything the right way, and I wasn't getting paid. And I was being told, well, no, you're still doing something wrong. I'm like, I think I know what the problem is here. And so that's where I still give them the proper bills. I have a super bill. I have all the codes on it. I give that to the patient. We have information on our website about how to submit it over. And then guess what? They get to play the game that we get to play all the time, that our offices play all the time, as far as submitting it over to the insurance and seeking reimbursement. But the good thing is, when we're trying to submit it over to insurance, we're this third party. And so it's easier for the insurance company to bite that hand, because it's not the hand that feeds them. But all of a sudden, if we have our patients submitting it over there and insurance is pissing them off by giving them a hard time, by just automatically rejecting it, by saying you didn't submit this, even though they know that they submitted that, all of a sudden they're realizing, hey, insurance is kind of a bunch of BS. And so they are biting the hand that feeds them. So they're starting to see, and guess what? Eventually patients are going to be like, you know what, maybe I shouldn't be paying for this, or not at the level that I should be paying for this. And then once all these insurance companies and hospital CEOs and everything like that, once the money stops trickling into them, that's where reform is truly going to happen. So this is starting in a small kind of thing, but I'm really hoping to make it a bigger, thing that becomes a true movement about taking medicine back.
Yeah, thank you. Before we move on over to Dr. Tierney, there's a follow-up question that just appeared in the chat. So a patient can have insurance and also submit for reimbursement to a direct primary care?
It's really a tricky situation, and I would err people to be very careful on if they go in, if other physicians decide to go down the direct primary care route. I keep it simple. I do not give them super bills. I do not go down the road of billing, coding, anything like that. It just, at the end of the day, patients, I think, would come back to me when they are getting rejection and this and that. It's just more work than the simple cash bill done. It's me and a medical assistant, and I'm in the process of expanding provider to another provider right now, so that the office will continue to expand. But to keep my staff low, the best way to do it is just not mess with insurance. I do tell people, my patients, that something similar about, you can use insurance just for everything except for my services. And so they understand I take their insurance, but I only bill it for labs. If I need to get, in something like a imaging test and we have to fight for prior authorization for the few that I do, it's really not as much of a pain to me anymore to do one or two a month. It's really very low, rates of having to deal with the insurance companies in that regard. As far as any type of billing, no, I don't do that. I think it's just too much of a hardship. I tell them that they're the decision makers as to where their healthcare dollars go. If they know that their panel of tests are going to get covered, I'm happy to send it off to the lab and have the lab bill their insurance, and it's off of my plate. If a bill comes back to me, and I have my labs separated, one lab, all cash, the other lab, all insurance. So if I know a lab is coming through and I'm getting an error on the insurance-based one, not on me, something happened, and I put it right back on that lab to get corrected. Sometimes we just have to give them a copy of the insurance card, but we're not having to do anything, no further steps. When I was in corporate healthcare, I was contracted with the VA to do acupuncture. I did other work with veterans as well, but mostly I was an acupuncturist for them. And so when I initially left and opened up my DPC practice, I thought, well, maybe I could just contract with the VA. And I started trying to even just do their billing. And I realized quickly it was just not worth it for how small of a practice I was. And so when you start to talk to the patients about it, I would give them a super bill if it came up. A lot of them actually just didn't care. So if they did come to me and ask for me, I would give it to them and then they could submit it to the VA. There were other ways around it. And I realized that getting those other ways set up so that the patient could then do the steps that they would need to take, I found was a whole lot less of a burden on me or my staff.
Yeah, no, that's a good point. And that kind of leads to, another question that was in the chat about concierge medicine, because these people, they pay these premiums and they get full access, or hopefully full access, or 24/7 access, depending on how much you pay. And sometimes to order labs and all that, that's sometimes, billed through insurance companies. Sometimes it's all cash based too. And so I think, it really depends on how much work you want to do, right? And how much work you're putting onto the patient, how much work you're basically saying, no, this is why I'm breaking away from the system. How much work do you really have to take on? So thank you.
Yeah,
All right,
I just wanted to add one thing also. As far as submitting over to insurance, the one exception about submitting is if they have Medicare. When you're opted out of Medicare, legally, you can't have patients submitting over there. Doesn't stop some people from doing it, but we have paperwork that says, I understand that if I have Medicare, I can't be submitting over there. What's crazy is I had to go through all this stuff. I'm sure you went through this too when you opted out of Medicare. And then when a patient submitted over there, Medicare sent me some paperwork, said, hey, we got this. We see that you're opted out. If you don't send anything back to us, we're just going to opt you back in. I'm like, how can they pull you back in? It's crazy how they can just do that. And so we really try to make sure we guide our patients the right direction with that. Yeah, sometimes when we submit that stuff to them, it does become a little bit of a pain in the butt, but we try to make sure that we minimize how much that's stressing. Again, I have a very bare bones staff and I try to make sure it's not, we direct people to our website a lot. And so that's where we just try to turf it essentially and just say, yeah, that's the reason. And they're like, this kind of sucks. And we're like, yeah, that's the reason we left it. I know, right? And so that they kind of get that.
I think it's really important to understand the laws before you go into direct primary care. And that's not just the federal laws of what was just mentioned about Medicare fraud, that I do a lot of counseling with any patient, even my uninsured patients. Every single patient of mine signs a form with a discussion that I have opted out of Medicare and Medicaid. They cannot be billing Medicare or Medicaid for any service that I provide, even if they are uninsured, because I've already medically qualified 2 patients for Medicaid, but what if they applied on their own and I didn't know about it and then they went and submitted a bill? So from a legal protection, that's why I don't bill, but I also make sure that every single person that walks through, it's like their HIPAA form, my Medicare opt out. They have to sign both for protection. But there's also individual state laws that are really important to understand that vary, whether or not a state will allow a direct primary care practice to use that patient's HSA, or do they not allow to take that HSA? Because about 30 miles south of me, they're not allowed to use an HSA. In Pennsylvania, they can. So that's where understanding that is important, because some patients are like, oh, wait, I can use an HSA. And it's like, for now, yes, but I have to make sure I'm following the legal law, the legislation as to how that landscape could change.
Yeah, thank you. And you guys actually just answered another question in the chat about working with patients who have non-DPC friendly insurances like Medicare and TRICARE. So, I think bottom line is, you decide what you want to do, and if you want those extra headaches in your hair or not. But a lot of my colleagues who went into DPC, they basically say, yeah, no, we're not taking insurances. We're just going to break away completely from it. So thank you.
Just one point on that. A problem with insurance is their HMOs, because they have to elect a provider. Doesn't mean you can't see them, but you have to be really honest with them up front that I could be an issue with signing up to me, because I'm not signing up to our clinic. I'm not able to send referrals to specialists without you having to pay cash for those. because they would need an in-network provider. And then when you're trying to do prior authorizations and things like that, I'm not able to do them because I'm not in network. So that does pose a problem for your patients as far as patient care goes. There's been some methods that I don't have currently a patient that does this, but I've heard that some patients will still stick with a provider in the system for once a year type, visits, but then everything else they're using direct primary care. So there's ways around it if a patient really, really wants to just choose their provider truly based on the care that they receive.
Yeah. All right, so we're going to go to the next question. This one is for Dr. Tierney. Is there anything that you recommend must be included and is often missed in patient contracts for enrollment and monthly subscriptions?
I mentioned the Medicare opt-out form. That is a must, but honestly, you need your HIPAA, you need all those things. And a lot of times you don't even necessarily, if you're not billing insurance, HIPAA kind of, it's not the same, but I still follow every bit of HIPAA that I would have under billing insurance. And then I just got my resources from attorneys I've worked with and making sure I follow their recommendations and cross-reference them with other direct primary care physicians in the community that have been in this model for a lot longer and have even written manuals on helping other practices get up and running. So I would cross-reference them to make sure all of my I's were dotted, my T's were crossed, and things like that. Because you have to protect yourself, you have to protect your license, but at the end of the day, it's really basic forms and you'll be good. You also, another place to check is your malpractice of what forms maybe the malpractice specifically wants. For instance, when I started, some forms weren't needed, changing malpractices. Now I need certain consents for telehealth, this like a certain form for telehealth, a certain form for this. So they just sign a whole bunch when they sign up, and we make sure that they understand what it is that they're, signing.
Yeah.
They also get a copy of everything, which I think is nice because I know when I have to sign these forms for my children at the pediatrician, I sign a black little signature box and I have no idea what I'm signing. I mean, obviously I know what they are, but imagine somebody who goes into that practice and they're, not educated. It's really a shame. Whereas my patients, everything's loaded onto their EMR and they can see a copy of every single form that they've signed.
Wonderful. Dr. Clearfield, anything to add?
I was just gonna say, when I got started with all this, there's a lot of those little legal kind of things. My clinic, I've never said it's like a direct primary care. I'm doing more direct specialty care. But there's a lot of direct primary care aspects that I adopted. And anybody that's in the DPC community probably knows. Do you know Josh Umber? Yeah, so a lot of people know Josh, and he's founder of Atlas MD, which is both an EMR and just a direct primary care kind of model. And so he was profoundly helpful when I kind of got started. I just got introduced to him, and they had a lot of resources available for free, just that had some different paperwork and those forms and the legalities. And then I had to look into specific Texas kind of things too. So I did discuss with my attorney, to make sure that I had all my ducks in a row when I got set up. But as Mary was saying, you gotta just make sure that you have all those kind of ducks in a row. But it doesn't have to be so overwhelming. It's actually pretty laid out, and a lot of people have done that groundwork, and that's part of like the consulting kind of work and stuff like that I do. It's like, hey, I've done all this groundwork already, so let me kind of help lay this out. Let me just present it to you, and so that you can just kind of just have less angst about needing to kind of start something like this.
Unlike corporate healthcare, where everything's like private, in the direct primary care community, there's a lot shared. And as long as it's following with what your state needs, those resources are out there that you don't have to kind of reinvent the wheel and produce them yourself. Just make sure that they fit for your clinic and also for the state, and you're good.
Yeah, I think that's a really important point. There's a lot of us out there, even in the sports medicine community, we kind of share, informed consents and consents on procedures already and say, hey, what do you include in your consent? What do I include? And so there's a lot of collegiality there as well. I think we're all here to support each other. All right.
Yep.
we'll get to the next question here. This one is going to be for Dr. Clearfield first. It's a really popular question that comes up all the time. How did you figure out or research your business model of what you want to charge? And oftentimes people use Medicare rates, but does that really translate to direct care costs?
Yeah, so excellent question. And I will say it can definitely vary. And the one thing is you can shift your prices as well. And I have updated my prices numerous times. We do a complete reevaluation pretty much every January 1st. And I kind of look at where economic inflation is going also. I look at our costs that we have and see how much our supply costs and everything like that has adjusted. So I need to see, do I need to adjust my prices? Do I need to bring my prices up? This year, I actually took some of my prices down because I felt like I wasn't comfortable personally, and ethically, just like where I was like, I felt like I was charging a little bit too much maybe for this procedure. And so I was like, let me kind of bring it down a little bit. And I've actually been able to promote it that much better. When I started off, I looked at, I stumbled across this website called healthcarebluebook.com. I'm not sure if it's still free, but you could look based off of your geographic area, what different E&M, what different CPT kind of prices were, what different J-code prices were. And so that's where I kind of take a look, and it had a spectrum of prices. And you could say, okay, I'm going to go ahead and I'm going to put myself, at the cheaper end or the middle end of that, or the expensive end. You can kind of decide that. I will say when I first got started, as from a consulting fee, I initially had my consulting fee at, it's like I saw it could be anywhere from like $50 to like $400 or $500, as a subspecialist. And so I was like, you know what, for the amount of time and everything like that, let me just start at 150 and let me just kind of do that. And right as we got started, and I was also, because I had a non-compete from my prior job, I was 22 miles away from my prior job. So I was in a slightly different area. Still some people that kind of knew me from before, but overall a new patient cohort that was kind of finding out about me. And we saw that a lot of people, when we would discuss with them on the phone about the consult fee, they'd say, oh, you know what, I'm going to look at something else. So then we had a promotion. And when you set your own prices, you can discount it or whatever, or have promotions or discounts or whatever you want. And so we had a promotion and we brought the price down to 99. So less than 100, kind of that Walmart kind of thing. Just keep it less, 2 digits, not 3. And then we saw that overall that got people in, people came in. And so we had our price set at like $99 for a new consult and I did that up until a year ago. But then a year ago, I started including diagnostic ultrasound as part of my initial evaluation rather than an additional cost. And we expanded our time out so that we have a full hour with the patient. And so I include a lot more, but so we increased our price. And granted, sometimes the price is a deterrent, but I don't feel like it's too much of a deterrent. And I've trained my staff to really make sure that they, can handle the patients when they say, hey, what if the patient says this? What if the patient says this? So that they feel more equipped to be able to kind of still get the patient to be like, oh, okay, I get it. That seems like a good value to me. I'm going to come in. And once they come in, the big thing I say is our E&M is E&M. Is that what kind of keeps your lights on? And, it's like when I was part of the orthopedic department, E&M was not something that we got reimbursed well for. It was CPT that we got reimbursed well for. When I went over into a primary care setting, even though I was sports medicine, they didn't use the sports medicine taxonomy code. They only used the family medicine taxonomy code for me. And so I was getting reimbursed at family medicine rates for sports medicine orthopedic procedures. And so it didn't make financial sense for me it was a model that rewarded seeing patients, pumping them in and out, referring them out, not taking ownership. And so that was part of that ceiling I was talking about that I kind of faced. And so, when I kind of started this, I said, okay, how much should I charge for this? What is the value that I'm bringing to this? Sometimes you might start at a little bit of a lesser thing. And sometimes after you've been in there, you also have to look at your market that's surrounding you. And so when I moved to where I am now in North Richland Hills, which is a more affluent area than where I started down the street in Lake Worth, I needed to change my prices just so that because if you are, let's say that, there's another clinic down the street and they suck, but they charge more than you, then people sometimes will put you at a lesser level too. And I sometimes call it the dollar store effect. If I say that I can do this procedure for you and it's amazing and it's going to help everything, and they're like, how much does it cost? And you're like, $5. Do you really think that somebody's going to buy into that? Now, if you say it's $5,000, they'd be like, oh my God, okay, that sounds amazing, but I can't afford that. So, okay, how about $1,000? Oh, okay. Yeah, I can do that. And I get, and so they're going to be invested in that. And if you buy a shirt at the dollar store and you buy the exact same shirt at like a local department store and it costs $50, even though it's the exact same product, you're probably going to take better ownership of that $50 shirt just because you invested, you have skin in the game. And so that's where you want to make sure that you set your prices enough that somebody's going to have skin in the game. That's where they're going to embrace their care a lot more too. Because sometimes people just take for granted when they're kind of going through insurance. It's like, oh, you know what? I didn't have to put anything into it, so I'm not going to put anything into it. So I see better outcomes with my patients because they're invested in their care. They're truly invested in their care. Objectively, they're not getting a bill down the road that might be more than what I'm charging. They see how much it is right now, and they're going to embrace that, and then they're going to work on it.
Yeah, Dr. Tierney, anything to add?
A few different things of how I came up with my rate. I mean, first of all, I am a hybrid. So I really wanted to appeal where majority of my patients were seeing me and, joining a membership where they're going to be mostly coming for their primary care and then also orthopedic care in addition to that. So for me, it was really important to look at the market of just what Medicare charges for things and be able to give people a comparison. Hey, this level is going to be this under insurance. My charge is a flat, this is what you're going to be paying for your labs. But also what other direct primary care practices in my area were doing. I'm the only hybrid in Lancaster County. However, I had a few other variables that I think were really important for me when I was starting out. I'm coming up to 2 years, so just shy of that. But I had to move about 45 minutes away due to my non-compete, which thankfully was closer to my house, but in an area that I actually had to kind of rebrand myself, get my name out there, do all a new marketing. I had luckily a number of patients that followed me, but still I am in an area of the county where I can still get some parts of the county that are higher end, more affluent, but they also are surrounded by a lot more of the direct primary care practices around them. If they come to me, they're willing to travel further, but they're traveling for the care. Most of my market, though, is actually of a lower socioeconomic status. And that actually is a community that's really important to me. It's very rural, very blue collar, a lot of farmers, which is really near and dear to my heart because I grew up on a farm, but also just people that I think benefit so much more from the type of care that I provide. That have access to regenerative medicine and basically either no insurance or high deductibles, health sharing ministries, but a much harder recruiting area to charge higher prices. So I had to be really smart and look at where a lot of the other practices are, because the thing is, I looked at it as I could always go up, and I have gone up. But I was leaving a job where I was making more money and more than my husband. And I had to basically make sure that I could balance what it would be like opening a practice completely from scratch with really no sure idea of how many patients would be signing on, and balance how long we could possibly do that without it hitting us financially. So I really felt it was very important not to overshoot that mark, because in my community, people know each other. And if I overshot it, it might take me a lot longer to recover by then lowering the prices. You could always go up. And I felt that if I incrementally go up, it's a whole lot harder and I probably could retain more patients. So that was really important to me. I've heard a lot of other DPC doctors say, keep increasing it until you start losing patients. But you do see Josh Umber, as Daniel mentioned, he's done research and you can actually see the amount of direct primary care practices that actually can fail that way. And I was nervous about that. So I wanted to be really cautious and make sure that I fell within a range of where my other practices were, and also comfortable for what my patients could actually handle. So I'm at a point where I think I found that mark, but it can definitely certainly go up when it's time.
Yeah, no, that's an important point. I think one of the talks at this year's AMSSM, Clarence Lee talked about kind of breaking away and starting your own practice, and he was asked this question too, and I tend to agree with him. The beauty of direct primary care is that you can charge whatever you want, but it kind of depends on, as you guys have said, the patient population, whether or not they're able to afford it or not, but then it also depends on the market and your competition, right? So if everybody else is, let's say, charging $500 for this specific service and you're charging $1,500, well, there could be a reason, but chances are you probably do have to lower it a little tiny bit. So I think that's an important point too, is that you can charge whatever you want. And Clarence, he and I have been friends since medical school, and he talks about his experience in public speaking and getting paid for it. And so he said, well, at first I asked for $1,000, and then they said, yeah, sure. And then he asked for $2,000, and then he asked for $5,000, and everybody kept saying yes. And then he asked for $10,000, and they said no. And so that's when he knew, okay, yeah, I got to back it up a little bit. So I think, it depends on the market as well. But there have been some follow-up questions that are kind of linked to this as well. So the follow-up questions are through the audience, and I'm keeping a close eye on time here. So I'm going to kind of combine some of these questions. Approximately how much do you charge for diagnostic ultrasound, if you don't mind sharing? How about ultrasound guided procedures? And is it hard for patients to get procedures with you for cash paid versus when they can get it covered by insurance? So Dr. Tierney, let's start with you.
So my ultrasound, I consider just part of my services. So if they are not my patient, they're being charged a non-member fee, and that's about $200. And that includes the ultrasound. It's not a separate charge on top of it. You're just being charged the charge for that day. If it's a member, it's all looped into your membership. So I like to say you're not going to be nickel and dime for every little thing that happens. If it's an extra charge to me, then it's going to be a charge to them, but I don't charge them extra for that.
How about you, Dr. Clearfield?
So with the ultrasound, I've definitely kind of altered that. Yeah. So, also just keeping in mind, you have overhead. You have overhead of, I had to pay for my machine. My machine is paid off, but, it's also required some servicing and supplies. And then also just think about all the hours of education that you put into yourself with that. So so the first thing I just want to say is put value to yourself when you're kind of looking at these prices. That being said, so my initial consult right now is $199. Established patient new problem is $185. That includes doing a diagnostic ultrasound, which is typically going to be a limited kind of scan, typically not a complete scan. Now, that being said, if I need to do like a complete scan on somebody, I also do diagnostic neurosonography. And so I have a lot of physiatrists and neurologists that send to me some of their cases where some of the electrodiagnostic studies are a little bit vague. And so I might need to do an entire ulnar nerve, all the way up to the brachial plexus or median nerve. And so I do charge $250 when I do that like complete kind of diagnostic neurosonography. And we just make sure that prices are nice and transparent for the patient up front. So as far as talking about doing injection based kind of procedures. So whenever I'm looking at trying to, present patients with their options, and I'll talk about like, hey, we can do, I have a whole treatment spectrum that I present to the patient, and it says, here's steroid, here's viscosupplementation, here's nerve hydrodissection, here's, shockwave, PRP, stem cell, all these treatments that we kind of offer. And then I lay out, this is how much these kind of procedures cost. If they're like, can I get this done at my, orthopedist or something like that? I'm like, yeah, you can get that done over there, but I mean, I could do that for you right now. If you want, it's going to be this much. And so like, if I'm doing just a plain joint injection, we charge $160 for that. Did I start at $160? No, I started a lot less, but I moved it to $160. If I use ultrasound, we add $80 to it. So pretty much most procedures are either in that $160 or $240 kind of range. And that's where it's kind of evolved to. It's not where it started, but that's where it's evolved to. And that's where the prices, I think I haven't had any flack from patients saying, oh, that's too much, or that's kind of ridiculous, or anything like that. So, you have to, sometimes you have to, again, figure that market out. It's a little bit of trial and error. And sometimes you can always change it back. You can always, like, so with, we did this business fellowship last summer, and they really wanted us to inflate our prices. And so we did. We inflated our prices. I tried to blindly follow it. I didn't feel good about it. I wasn't on board with it. I felt like I had I had ethical kind of issues with just how I was charging people. And so after trying to do it for about 5 months, I said enough, and I decided to roll it back. And ever since I rolled it back, I've been closing and selling so many more of these procedures for less money. But it's like, that's great if you charge more money, but if you don't get people to actually commit to it, and if you can't commit to it mentally, then you're not going to be able to really sell patients on it too. And so that's where, again, you need to feel good about what you're doing. And I always said, it's like, when I've done this, I want to make sure I can sleep well at night. I know there's people down the street that are charging twice as much as me for some of these procedures, or 3 times, and they have significantly less training. They're not doing any kind of imaging guidance. They don't have the background understanding of what it's kind of doing. But I feel good about what I'm doing. And so ultimately I sleep well at night, and I'm making a good living.
Yeah, no, I think that's important in anything that we do, not just, charging people for, or charging patients for reimbursement, or pricing services like this, and taking care of patients. I think that's a really important point too. I sleep really well at night knowing that I took care of the patient, the best that I could, in doing the right thing for the patient. And sometimes you have to commit yourself to doing that. So we're almost out of time. So I am going to we are going to do one last question, but I am going to combine 2 of them together because I think they're kind of related. And one of them is, how does DPC work in low socioeconomic areas? And since we're talking about money, if you wanted to start your DPC in whatever area, what do you recommend as the startup capital? And can you talk about profits and salaries compared to when you were employed? Is there a difference? So, Dr. Clearfield, why don't you go first?
So, and maybe Dr. Tierney is going to be able to answer this a little bit better, just because she's doing a true DPC, and I'm not set up in a DPC. It's more of a direct specialty care, sports medicine, orthopedic kind of practice. As far as it's like, how am I doing financially compared to where I was when I was employed? If you expect to start and pick up exactly where you left off, when you were kind of employed, to say, I think you're kind of joking, you're kidding yourself. If I had to kind of go back, and part of why I do the consulting also is, I've had things I've done really well, and I want to teach people that, but I have some things I've done wrong, and I want to make sure people don't repeat those mistakes. When I started this, I had been studying the model for a couple of years. I saw that the ship was kind of going down with the practice I was at. I had to start my clinic a year. I really wanted to get my clinic started in 2020. And I ended up having to start it in 2019. So I wanted to build up savings more. And so because I didn't have as much savings, I did have to go on a little bit more debt when I kind of started it up. And, we put it on some credit cards, and 0% interest for like the first year. But then guess what? After that first year, it just kind of piled up. And we had a whole plan on paying that down, but then my wife got breast cancer, and we got that. And so, she's doing well, she's in remission, but we're just still paying down these bills from that. And so sometimes life gets thrown at you. So it's like, if I had some more savings coming into it, that would have been great, just because sometimes life kind of throws its curveballs at you, and you need to just be prepared for those other stuff. And it would be nice to have, like, if you had a year's worth of salary so that you could be comfortable and not go into debt further when you kind of start this up. You're gonna just have that more comfort level of, okay, it's all right to be slow right now, and I can work a little bit harder on this. And I worked at first 3 jobs. I worked, I had my Moshe's medicine. I taught part-time at the medical school, and I started moonlighting urgent care. And then once I found that motions medicine was picking up enough steam, I dropped off the urgent care first because I hated it. It was morally just, and then I left the teaching when I said I needed to kind of move full time over to what I'm doing with this.
Yeah, Dr. Tierney.
So the question on the lower socioeconomic status community, I would err on the side of saying I'm not in that true aspect. I just have a lot more blue collar folks that are more cautious with their money. And there are some people that struggle on part of the county of where we're located. But for the vast majority of Lancaster County, I wouldn't say that it's too much of a lower socioeconomic area compared to a lot of other like inner city populations, but there are actually clinics that are very much thriving. You can look up a direct primary care physician that's in Detroit. He's actually well known. He's been doing it for a very long time. Plum Health is his practice, and he actually talks a lot actually on a lot of his, I forget the percentage. I want to say it's close to 40%, if not 50% of his patient population is Medicaid. And he truly believes that if you provide good care and accessibility and transparency of cost, patients even of that category can and will seek out direct primary care. So it's about the care. And of course, the price has to be able to fit that area. So I wouldn't say I'm in that necessarily, but it does certainly, I think, a point just to be made. As far as capital, so because of the situation that we were in, I'm a very cautious person financially. I don't like debt, so I tried to pay down on my student loans as much as I possibly could, because I took a little over a year to make this decision. And in that time, I did a lot of research, talked to a lot of DPC doctors, did a lot of just, learning on my own. And what I also did during that time frame is I paid down debt so that I would have less debt going into this so that our monthly expenses could be lower. But when I opened, I really wanted to open in an area, in a clinic that would be needing DPC. I wouldn't have as much competition for the other providers that were in Lancaster County already, but I had to be really cautious with the rates as to like lease costs and everything else, because if I was afraid of failing. So if I failed, I didn't want the debt of what that lease would be on my family. So I took a very small clinic. It was only 2 rooms. And so what I was able to do was I just moved. A month ago, I moved to a much larger space when I knew confidently I was in a spot where I could. So I negotiated a 2-year lease. I got it. It started in technically May because we needed renovations, but I made sure that the renovations were bare bones of what would make that practice aesthetically look the way I wanted, but not break the bank. So I actually opened with not a lot of technology and all these other things. I started with just my butterfly ultrasound, just all the bare basics of what I could do to get up and running. And it was less than $10,000 for everything. So that was my story of keeping it low because I was afraid that I would financially put my family at risk. Thankfully, we worked really hard and I was able to move because I knew if things go right, I think 2 years should be hopefully that point of where we are ready to move. But if not, I still only have a year lease to then re-sign each year till the point of when we can move. And the stars aligned where I moved in to share space with a physical therapy office, and it's been great. And now I've put a lot more money into it, but I'm still not in debt because of it. I think it's a really important point. You can't go into this with the assumption that you'll make the same amount of money. I did not. So I'm finally making the salary of what I left around where I was at leaving corporate medicine, but it took a while. It took a while to get there.
Yeah, no, I think it's important to realize that any business that starts, you are going to lose money in the very beginning because you have that upfront cost. And so I think it's a little premature to assume that, oh yeah, you're gonna hop into it and then basically you're gonna be swimming in cash. In terms of low socioeconomic statuses, I think a lot of patients, they assume that the insurance that they have is free because they don't really see that cost up front, or they don't really see it out of their own pocket. It's already kind of taken out of their paycheck. And so if usually how I explain it to patients, or I explain it to other people, is that I say, you have to be upfront with the patient. You say, you guys are paying for insurance, whether you know it or not. It's just coming out of your paycheck, and you either don't notice it or you know it. And so, to, let's say, model a service charge after Medicare or after the insurance, I think it's appropriate. But, you just have to kind of explain that to the patient. So obviously, I think in low socioeconomic statuses and patients in that environment, I think, yes, you are absolutely right that they are more prudent with their money. They are more observant with how they spend their money, and they're more cautious with their money, but they're still spending money. So, yeah, are they going to spend a little more than on top of their insurance, or are they going to leave their insurance and then come with you instead? So I think that's an important point to make to the patient too. So great, we are out of time. There has been lots and lots of questions. Dr. Clearfield, did you have any closing words?
Yeah, I had a couple. I just, couple of just quick closing kind of points I want to make, to make sure I kind of fit in. Because where I started out, it was a lower socioeconomic kind of group in that area. I kind of started subleasing out of this wellness center and minor emergency center that they had there, and they had this cash-based minor emergency center and family medicine. Oh, are we still on?
Yeah, we're still on. I just
Okay.
basically shared just for
Okay.
other people who want to contact the both of you. So
Gotcha. Okay.
that's why I'm doing it.
But yeah, so I started out over there, and I one of the things that just really rung home that some of the providers that worked out of that clinic told me is patients they will pay for quality care. If Medicaid was delivering the care that they needed, then they wouldn't be seeking outside of that. But guess what? A lot of times the system lets people down. A lot of times people don't feel like they're heard, they're not seen, they aren't addressed, their concerns aren't, and so people are going to pay for quality care. So if you can really bring quality care, people are going to pay for that. So that's just something I just repeat and tell people all the time. People will pay for that. The other analogy that I think really helps when just kind of thinking and getting patients the right mindset about thinking about insurance is think about it like car insurance. So if you get a flat tire, if you need an oil change, you don't use your car insurance for that. So I think insurance is helpful from a catastrophic standpoint. If your engine blows out, if you get in a major wreck, so if you have a major, orthopedic kind of injury and bones are sticking out and you need surgery for that, or if you have a stroke or a heart attack, have catastrophic insurance for those kind of things. But if you just need your oil changed, or in the case of seeing me, you have a flat tire, it's like you just pay for it. You just get it done. And why do you pay for it? Because your car is going to get worse. You're not going to do yourself a favor if you keep driving on that flat tire. So why are you treating your body any worse than you're treating your car? You can replace your car. You can't replace yourself. And so when you kind of put that perspective in for people, I think it clicks and they get, okay, I get it. I understand what I need to do with this. And so that gets them in the right mindset.
Yeah, thank you. Dr. Tierney, any closing words?
I would just say that if those are anybody here is interested or who listens to this, you're more than welcome to reach out to me personally. But also, if you're just interested, go out and learn. Listen to as many things as you possibly can, whether it's podcasts or read books, or go out and find the DPC doctors that are in your community and reach out to them. We love to chat with people about the model because we're really passionate about it. And I've asked my medical assistants, the ones I've worked with, is this better than working in corporate medicine? And separately, they actually had the same thought that I had, which I shared with them. I've actually said the same thing in my own brain, which was the best day in corporate health did not trump the worst day in DPC. There are bad days in DPC. There are some really hard ones. But at the end of the day, I still feel that this is just an overall better life for myself, my family, and it's the physician that I've always wanted to be to my patients. And that, even if it's a hard day, that always makes me excited to start the next day. And I think going into a career like medicine, burnout's so high, careers are much shorter than they ever have been, and you have to love what you're doing. So there's a way to love it in a better way. So
Yeah, no, thank you. We are out of time, but thank you both for giving this being on the panel and giving this talk. I'm sure. Well, there are plenty of other questions, and so hopefully they can reach out to you guys if you don't mind. And so, like what Dr. Clearfield has said, he has a consulting service as well called Physicians Unchained too. So please feel free to reach out to him. Thank you, everybody. And just remember the next sports economics webinar is going to be on sports medicine practice in the FQHC setting. So a little bit of leading into that as well. It's going to be August 28th at 8:30 p.m. Eastern Standard Time. Dr. Julian Perez is going to be giving that talk. So thank you, everybody, and glad that you guys can make it. Thanks, Mary. Thanks, Dan.
thank you, Eliot.
Thanks
This
for
was
having me.
fun.